pulmonary fibrosis is a chronic progressive fibrosing interstitial lung disease with unknown cause. It causes irreversible scarring and damage to the lung tissue, leading to decline in the lung function. So it will lead to decline for the FVC and the DLCO. They usually come with progressive chronic exertional dyspnea with persistent dry cough over many months or years. Usually they are male and over 60 years old. Common finding, they will have digital clubbing and bilateral inspiratory crackles at the base of the lung, classically described as Velcro crackles. And here you can hear the sound of it. And as you can see, the crackles come in inspiration, but they disappear during expiration. Diagnosis of IPF is a diagnosis of exclusion. It means you rule out all of the causes of interstitial lung disease. So environmental and occupational exposure like cilia, scoliosis, and asbestosis, and hypersensitivity to pneumonitis like farmer's lung, connective tissue disease like SLE, rheumatoid arthritis, and drugs that induce lung disease, or drugs that induce interstitial lung disease like bleomycin, methotrexate, cyclophosphamide, and others. We mentioned because of the restrictive pattern, there will be reduced FVC and DLCO, and chest X-ray will have reduced lung volume with bilateral reticular opacity, especially in the lower zone. But what really makes the diagnosis is the HRCT. Here is this HRCT, and you see a clear pattern of reticular abnormalities, articular distortion, and honeycomb appearance. So lung biopsy is not required for definitive diagnosis, but it may be used in some cases. And the management, there is two antifibrotic agents. There is perfidone and nantidirumab. They are the first line treatment, and they slow the declining of the lung function, and they reduce the risk for acute exacerbation with modest survival benefit. Pulmonary rehabilitation improves exercise tolerance and improves the quality of life, so it's recommended for most patients. And supplemental oxygen is indicated for people with resting or exertional hypoxemia. It improves the exercise capacity, improves the quality of life, and may prevent complications like pulmonary hypertension. They should be updated with vaccination, especially influenza and pneumococcal vaccination, as these infections with people with this impaired lung will cause higher risk of morbidity and mortality. And lung transplantation should be considered in patients with progressive disease despite of optimal therapy, particularly in those with minimal comorbidities, as it can significantly improve survival.